So our next speaker will present to us difficult cases in rheumatoid arthritis. Dr. Naji is a full professor and head of department of rheumatology and clinical immunology in Sam Lewis University in Budapest. He had been involved in multiple publications in the field of immunology and rheumatology as well. So I think we can start the presentation.
To start with the objectives. So currently in the everyday clinical practice, we are working according to international guidelines and recommendations. And actually, according to the EULAR recommendations for the treatment of rheumatoid arthritis, we know that the treatment aim should be reaching the target of sustained remission or at least low disease activity in all cases. But the problem is that at least 20, 30, or sometimes up to 40% of the patients seem to be refractory. And that's why a few years ago we initiated a new work inside EULAR. And so the task force which deals with this work try to take care about these 20–30% of patients, to create a terminology for these patients, to define this patient population, and also to create a guidance for the management of these patients. And basically what we try to do to identify contributing underlying factors, to adjust pharmacological and also to consider non-pharmacological treatment options. And basically what we did, and what I will try to explain shortly, are completely in line with the current EULAR and ACR recommendations and ACR guideline for the management of difficult to treat rheumatoid arthritis, and most of these are already published. So I would like to talk about the terminology and underlying factors first of all. So if we would like to somehow call this patient population, then there are various options, such as multi-drug resistant, refractory, therapy resistant, or difficult to treat disease. Basically, the task force suggested to consider difficult to treat because this reflects best the clinical situation that we are dealing with. And difficult to treat is a widely used term in various fields in clinical medicine, including pulmonology, such as difficult to treat asthma is widely used, or cardiology, angiology as difficult to treat hypertension is used, and also in infectology, various difficult to treat infections is quite widely used. So if we hit difficult to treat, as a PubMed search, we will find a lot of hits. And if we now search for difficult to treat rheumatoid arthritis, we will find a lot of hits as well, because now it seems to be a very widely studied patient population. What are the potential reasons of being difficult to treat in rheumatoid arthritis? So probably major factors are comorbidities, behavioral and lifestyle factors, failure to various kind of medications, and rapid radiographic progression. What kind of comorbidities are we dealing with? First of all, we are dealing with comorbidities which limit treatment options and or fuel inflammation. For example, infections, malignancies, which are generally associated with systemic inflammation, and some other diseases such as chronic heart failure or kidney failure or osteoporosis, which will limit treatment options and thereafter may increase the inflammatory activity. On the other hand, some non-inflammatory conditions may influence disease activity measures such as fibromyalgia or depression, which are pretty frequent in rheumatoid arthritis. The behavioral and lifestyle factors are also important. Obviously, just as in all chronic diseases, medication non-adherence, non-persistence, socioeconomic factors, obesity, overweight, or smoking are major factors. Other factors of the difficult to treat disease are the refractory, the reasons of the various causes behind refractory disease, refractory to conventional synthetic, to targeted synthetic, or to biological DMARD. And one of the reasons why someone might be resistant to biological DMARDs is that some patients may have anti-drug antibodies, and then that might be a potential explanation of the non-response. And the radiographic progression is another potential reason of difficult to treat disease. And in the real life, we frequently have a mixture of all these conditions. So many patients have comorbidities and behavioral problems. In addition, refractory to some kind of medications, and many patients have rapid radiographic progression as well. So let's see how we started this work and how could we finally make some guidance for the patients. So first of all, to see a little bit more clear what's going on with this patient population and what is the opinion of our colleagues about difficult to treat rheumatoid arthritis, we initiated an international online survey, and basically this online survey was completed by 410 rheumatologists across 33 countries, mostly European rheumatologists. And as you see here, this is the number of respondents from various countries. Colleagues from Czech Republic, Hungary, Germany, UK, Italy, France, Portugal, or Netherlands completed this survey in a quite high number. Basically, we asked what our colleagues think about difficult to treat disease, and we had several questions. Basically, I just would like to show you a few of them. So we asked, how should we define disease activity in case of difficult to treat disease? And here you see the options and the most selected options. And basically, the most selected option was that the DAS28, based on the erythrocyte sedimentation rate, should be higher than 3.2, or presence of signs suggestive of active inflammatory disease activity in case of the DAS28 is lower than 3.2. So that was the most selected option. Less selected option was the same criteria with the 5.1 as cutoff. And we had some other criteria, which is indicated with yellow or green, by itself the DAS higher than 3.2 or 5.1. So actually, we also asked our colleagues how should we define treatment failure history. And here again, the most selected option was that the failure of at least 2 conventional synthetic DMARDs and at least 2 biological or targeted synthetic DMARDs. Less selected but still quite popular option was at least 2 conventional synthetics and 3 biological or targeted synthetics, and you can see the other options as well. So basically, we have an idea what our colleagues suggest to have as treatment failure history criteria for these patients. We also asked our colleagues if we should include treatment with glucocorticoids as a criteria, and here we had several options as well, and the most selected option was unable to taper below 10 milligram prednisone or equivalent, and a little bit less selected, unable to taper below 5 milligram prednisone or equivalent daily doses. So basically, most colleagues suggested that yes, we should include glucocorticoid treatment with either 5 or 10 milligram or another dose. That was basically picked by 95% of the respondents. And we also asked our colleagues if fatigue should be included in the definition or not. As you all know, fatigue is basically very characteristical and very frequent in case of basically all chronic autoimmune inflammatory rheumatologic conditions. But our colleagues, based on the results of the survey, suggested not to include fatigue. And the reason was that fatigue is very common, but not specific for difficult to treat disease. So now when we had basically the results of the survey, we created with the task for a definition and the guidance, an EULAR definition and an EULAR guidance for the treatment of these patients. So let's see the EULAR definition first. And I'm sure that most of you already know this definition and met this definition before. Basically, the definition has 3 points, and all 3 should be met to have the definition of difficult to treat disease. The first definition is dealing with the treatment failure history. The second is dealing with the various signs of the active progressive disease, and the third is a kind of agreement or kind of like perception of the disease. So the first criteria says basically that the treatment should be according to the EULAR recommendations for rheumatoid arthritis and failure of at least 2 biological or targeted synthetic DMARDs with very different mechanism of action after failing conventional synthetic DMARDs, unless these are contraindicated. So all patients who fulfill this criteria then meet 1 criteria of difficult to treat disease. And actually in our clinical practice, really many patients are over at least 2 biological or targeted synthetic DMARDs. So it's very common. So the second criteria has 5 sub-criteria, A, B, C, D, and E, and any of them is enough for the definition of difficult to treat disease. A is that the patient should be at least moderate disease activity according to validated composite measures, including joint counts. And then, for example, DAS28 should be higher than 3.2 or CDAI more than 10. The second criteria include any signs, including acute phase reactants and imaging, or symptoms suggestive of active disease. For example, these might be either joint-related or other. And we all know that some patients may have joint symptoms which are not included in DAS28, like, for example, feet joints. The third, the C here in this sub-criteria, is inability to taper glucocorticoid treatment below 7.5 milligram per day prednisolone or equivalent. And this is basically a good compromise if we come back to the survey, because there we asked 5 and 10 milligrams prednisolone equivalent daily, and finally the task force decided to include 7.5. The fourth here subpoint is the rapid radiographic progression, which may happen either with or without signs of active disease, and the E is well-controlled disease, but still having rheumatoid arthritis symptoms that are causing a reduction in quality of life. And the task force felt very important to include this last definition, this last part of the second point, because in many cases, patients have non-inflammatory disease. For example, the patients may have fibromyalgia, and these patients have reduced the quality of life, and that might be the part of difficult to treat disease as well. So any of these A, B, C, D, E points may lead to meet the definition of difficult to treat disease, but we need to meet the third criteria as well, because all 3 are necessary for difficult to treat disease, and that's basically that the management of signs and or symptoms is perceived as problematic by either the rheumatologist and the patient. So if we have a patient who is fulfilling the first criteria and the second criteria because he's over at least 2 biological or targeted synthetic DMARDs and still have active disease, but the clinician, the rheumatologist, feels that he or she knows what to do with the patient, that's not difficult to treat disease. But if either the patient or the clinician feels that that's a difficult case, then the patient meets a difficult to treat disease. And the reason why we included this third criteria is that we try to create something for the practical clinical work, and it was felt that that's important, because difficult is always a rather subjective term. And now let's see what kind of points, what kind of recommendations could we create as a task force after having the definition of difficult to treat disease. as all EULAR guidances, this is based on a systemic literature review as well. So basically, we created some overarching principles, which are general principles and applicable to all patients. And the first one, the overarching principle, is that these points pertain to patients who fulfill the definition, which I just mentioned, of difficult to treat disease, and underpinned by EULAR recommendations for the management of rheumatoid arthritis, including the overarching principles. So this work should be used in the clinical practice together with the EULAR recommendations for the management of difficult to treat disease. And the B overarching principle is that the presence or absence of inflammation should be established to guide the pharmacological and non-pharmacological interventions. So one should always kind of try to determine what is the level of inflammation and if the complaints are rather inflammatory or non-inflammatory. And now let's see what are the recommendations, the points to consider. So the first is hierarchically, I think, the most important for the clinical practice as well. So if a patient has difficult to treat disease, then the first thing to do is to rule out the misdiagnosis or to study the potential coexistence of mimicking diseases. So that's the first step, to clarify and to actively, let's say, reassess the diagnosis. And there was really a very good agreement among task force members that this should be the first step if our patient has difficult to treat disease to reach an optimal treatment. The second is if there is a doubt on the presence of inflammatory activity, which may happen based on clinical assessment only and composite indices, that ultrasound may be considered for this evaluation. So in the everyday clinical practice, if it's questionable if a patient is active or not, then ultrasound may help to clarify, because on ultrasound we can easily support or easily a little bit rule out really active disease. The third point is that we should use composite indices in clinical evaluation with caution if comorbidities are present. And especially some comorbidities such as fibromyalgia or obesity may directly heighten the inflammatory activity and may lead to the overestimation of disease activity. In case of comorbidities, one should be very careful how to evaluate the clinical disease activity indexes. And the fourth point is regarding the treatment adherence, what is important, of course, in all chronic diseases. And here what we recommend, that treatment adherence should be discussed and optimized within the process of shared decision making. So we should discuss with the patient that treatment adherence is essential, and we should be sure that patients understand that the shared decision making is crucial, and then they should adhere to the medication. Let's see what was the fifth point. The fifth point was regarding the pharmacological treatment, and we recommend that after failure of a second or subsequent biological or targeted synthetic, and especially particularly after 2 TNF failures, treatment with a biological or targeted synthetic with a different target should be considered. So we suggest to change mechanism of action instead of keeping the same mechanism of action and jumping to another medication within the same group. The sixth recommendation is that if a third or subsequent biological or targeted synthetic is being considered, the maximum dose as found effective and safe in appropriate testing should be used. So for example, in tocilizumab or baricitinib, where we have various doses, one should always use the maximum tolerated dose to treat patients with difficult to treat disease. The next point is, the seventh point is dealing with the comorbidities again. And we recommend that comorbidities may impact quality of life either independently or by limiting rheumatoid arthritis treatment options. That should be always carefully considered and managed. The next point is dealing with hepatitis B and C, and for some reason we found really very little evidence for most comorbidities, but quite a lot regarding hepatitis B and C. And that's the reason why hepatitis B and C represent a separate recommendation, and we recommend that in patients with concomitant hepatitis B and C, infections, biological or targeted synthetics can be used, and concomitant antiviral prophylaxis or treatment should be considered in close collaboration with the hepatologist. The next one, the ninth recommendation, is dealing with the non-pharmacological options, and we recommend that in addition to pharmacological options, non-pharmacological interventions, including exercise, self-management interventions, should be considered to optimize management of functional disability, pain, and fatigue. And here we would really like to draw attention to non-pharmacological treatment options, and that's something, I guess, what is neglected in many places, and which can aid and which can help and to optimize treatment. The next one is regarding the education. We recommend that appropriate education and support should be offered to all patients to directly inform their choices. And the 11th recommendations suggests that considering self-management programs, which are crucial, relevant education and psychological interventions should be considered to optimize patients' ability to manage their disease confidently. So the 9, 10, and 11 are dealing with non-pharmacological options, education, and self-management programs. And basically, we were thinking if we may somehow visualize all these points, and we finally had several figures from those. This one was picked, and basically, if we have a patient who have rheumatoid arthritis with persistent symptoms, one should ask if this patient meets the definition of difficult to treat rheumatoid arthritis or not. If the answer is no, then basically we can still go according to the rheumatoid arthritis treatment recommendations and watch the patient, because at later phase the patient may meet the definition of difficult to treat disease. But if the patient meets the definition of difficult to treat disease, and here the letters indicate the overarching principles and the numbers indicate the actual points to consider, which we already mentioned, then we step by step go through because we would like to create really a clinical roadmap what to do with these patients. So as I mentioned, actively reassess the diagnosis, assess comorbidities which may mimic arthritis, interfere with arthritis assessment. In case it's needed, please use ultrasonography, and if then the ultrasonography does not confirm inflammatory activity, do not escalate DMARD therapy, and may even consider to taper DMARD therapy, and always consider non-pharmacological treatment options, and then always try to assess adherence, if there are adherence problems or not. And if there are adherence problems, please optimize adherence. And in case there are no adherence problems, then we have a patient who has really rheumatoid arthritis, the diagnosis is correct, and really synovitis, and that which, if necessary, was confirmed with ultrasonography, and the patient has good adherence. So we are at the patients who really have treatment-resistant disease, and one should consider here to intensify or switch DMARD therapy to manage comorbidities that limit rheumatoid arthritis treatment options. And in all cases, especially in the most difficult cases, one should carefully consider to include and to optimize non-pharmacological treatment options as well, in addition to pharmacological treatment options. And so this was the EULAR recommendation, and based on that, we wrote another publication, because all three publications regarding the survey, the definition, and the guidance were published in Annals of Rheumatic Diseases. You had all the relevant references in the slides. And so we also, in a separate work, consider the non-pharmacological treatment options, because there are many, and I think these are also important in all countries, including in Saudi Arabia and other countries, for patients if these are available. And these include balneotherapy, education, mobilization, etc., self-management. So basically, here we recommend just not as a part of the EULAR guidance, that all patients who have difficult to treat disease should be assessed by a psychologist. And so there are various options. Some patients need education, some patients need education and physiotherapy, and some patients may need education and psychotherapy and referral to a psychiatrist as well. And we may control the patients after a few months and either reassess or continue the treatment. And so both psychologists and physiotherapists should be assessed, should be asked to reassess our patients with difficult to treat disease. And in case of a physiotherapist, may suggest home exercise or supervised exercise, and that should be reassessed as well, and either continue or try to repeat the assessment by the physiotherapist again. And I already mentioned, and we have several publications about that as well. I just would like to show one, that comorbidities are a very important component of difficult to treat disease, and sometimes they overlap with extra-articular manifestations. Here you see what are our thoughts about the relation of comorbidities with extra-articular features. So comorbidities, some diseases associated with lifestyle factors, associated with pharmacotherapy or extra-articular features are listed here, and basically some comorbidities are associated with extra-articular features such as accelerated atherosclerosis or malignancy associated with lifestyle, or for example depression and anxiety are both extra-articular features which are associated with lifestyle and comorbidities as well. Here the message is that in case of difficult to treat disease, we should always carefully evaluate what we see is either an extra-articular feature, comorbidity, or seems to be both, and we should try to consider to advise to the patient lifestyle changes and optimize pharmacotherapy for the best outcome. And finally, I would like very shortly to mention our ongoing research regarding difficult to treat disease. Basically, what we are doing, we have patients with rheumatoid arthritis. Some are difficult to treat and some are not difficult to treat patients and healthy controls. And we collect blood from these patients. We do a very detailed physical examination, joint ultrasound, functional MRI, and a detailed psychological examination. And we perform PBNC transcriptome analysis. We also track all the clinical features and try to map the pain pathways in the brain and figure out psychological factors. And in addition to all these, we also have a full metabolomic information and measurement about the patients. So just very short preliminary data about this ongoing work. Then the patients are grouped into various groups. The low inflammation, high pain, rheumatoid arthritis patients, difficult to treat patients, high inflammation, low pain, and high inflammation, high pain patients. And I just would like to show you some data regarding the general health of these patients. So here again, you have the high inflammation, low pain, high inflammation, high pain, and low inflammation, high pain groups. So the general health is the worst in case of high inflammation, high pain. The pain catastrophizing scale is the worst, again, in case of the high inflammation, high pain patient group. And the depression is quite high in case of the high inflammation, high pain, and low inflammation, high pain groups. But in case of the high inflammation, low pain group, the depression is not so prevalent. So the depression is seen to be associated with the pain, which is logical. And we are doing functional MRI to these patients, and we are comparing the pathways, pain pathways in the brain. And basically, what I just would like to mention that we could identify in the brain regions from and where the pain pathways are altered in difficult to treat disease compared to the non-difficult to treat patients. And that's the middle central gyrus, basically. What you see here is that a multivariate pattern analysis identified this middle frontal gyrus superior. And from this middle frontal gyrus, the connections are either like increased or decreased. Everything what is yellow or reddish are accelerated, augmented connections between these regions. And what is bluish are decreased connections between these regions. But basically what we may say that the connections from this middle central gyrus are significantly altered to many other brain places in difficult to treat rheumatoid arthritis, and that seems to be associated with both pain and inflammation. And now we are currently working on to put together all these data, the transcriptomics, the metabolomics, the psychological, and the functional MRI, and to try to find out what's going on in the patients with rheumatoid arthritis, with chronic pain, and various levels of inflammation. So to sum up my talk, I would like to mention that we identified that many patients do not have either remission or low disease activity who have rheumatoid arthritis. So we initiated an EULAR work to identify these patients, to create a terminology and the guidance for these patients. And basically we used an international survey to receive some input from colleagues, rheumatologist colleagues, and then we created the EULAR definition and the EULAR guidance, which were both published and openly available from all around the world. So you can freely access these publications, and please go ahead and read these and let me know what you think about them and using your best clinical practice. And we are currently doing many research regarding pain, inflammation, difficult to treat disease, and one of them I just had a chance to show you. And the very interesting thing is that the pain pathways are altered in difficult to treat disease compared to healthy donors based on functional MRI, and that's what we would like to really clarify and publish as soon as possible. I would like to thank to all colleagues who participated in this EULAR work, first of all for EULAR, for the support, and all colleagues, especially who were in the steering committee of this board, including Professor McInnes, Nadia Roderis, Melinda Kedves, Attila Hamar, Elena Nikiporiou, Paco Welsing, Desiree van der Heijden, and Jaap van Laar, and to all other colleagues who were in the task force. And I would like to mention other colleagues who are participating in the ongoing research regarding difficult to treat disease, my PhD students, Lilla Tóth, and my other colleagues, Zsuzsanna Helyes, Judit Majnik, Edith Búzás, and Panna Királyhidi. And with this photo of Budapest, I would like to thank you for your kind attention, and I'm very happy to take questions. Thank you very much.